So I think we'll move on to the talk. So I'm introducing Dr. Priya Chavalwada, who is our pediatric cardiac intensivist, and she did her cardiac intensive care fellowship from prestigious hospitals in London and UK. So she is currently working with us in our Heart Institute as a lead pediatric cardiac intensivist. And without wasting much time, I think I will hand out to Dr. Priya. Priya, you can carry on.
So thank you so much for your introduction, sir. Good evening, everyone. Sorry for the technical delay. Is my voice clear? Hello?
Yeah, it's clear.
Okay. So today our topic of discussion is pediatric arrhythmias. I'm sure a lot of you are aware of the discussion we are going to have. A lot of you might have seen in your OPDs or in your emergency scenarios, abnormal ECGs and not knowing what to do or confused what to do when. So today we'll try and clarify some of your doubts. We'll just keep it simple and interactive. So feel free to answer. I'm okay with mistakes, wrong answers, any answer, I'm open to it. So please unmute and everybody has to answer, not just one or two. So with that, I'll progress to our discussion. So the objectives for today's topic is recognition of arrhythmia in a child presenting to the ER, diagnosing the type of arrhythmia, and emergency management and stabilization of the child. So when we talk about arrhythmia, we have to know about the normal conduction system and how the normal sinus rhythm looks like. So the basics of conduction system, we all know the SA node, AV node, and the AV pathways through which the electrical impulse transfers. So the electrical impulse is generated at the SA node, and from there it transmits to the AV node via the atria, and from there to the Purkinje fibers and bundle of his, and it gets transmitted to the ventricles. Based on this transmission pathway, we have certain waveforms that we see on the ECG. So when we say P wave, it means the activation of the atria, and we see that atrial depolarization as an upstroke. And when we say QRS complex, it means activation of the ventricles. And T wave denotes the recovery of the ventricle, that is ventricular repolarization. So when we say normal sinus rhythm, so what do you mean by normal sinus rhythm? I want you all to answer. So what is the normal sinus rhythm? What are the characteristics of a normal sinus rhythm? Am I still audible?
Yes, ma'am.
P wave will be present, and every P wave will be followed by QRS.
Okay.
And the P waves will be positive in lead 1 and AVL.
Just lead 1 and AVL, not 2. Okay, good. We have 2 points. Any more? Okay, somebody in the chat box was saying RR constant. Okay. Q wave followed by P wave. Okay. Okay, so can we move to the next slide? Okay, arising from SA node. Somebody is saying arising from SA node. Okay, they're all right. So normal sinus rhythm arises from the SA node, and it has a regular rhythm, normal rate for age, and every P wave is followed by a QRS complex, and all P waves are similar in shape and size, and all QRS complexes are similar in shape and size. And it is very important to have normal constant PR interval as well as QT interval. So why this is important? If there is prolonged PR, what will be the result? If there is long QT, what will be the result? We'll be seeing in the following slides. And we also need to have a normal upright T wave. So these are the characteristics of a normal sinus rhythm. Only when we know what is normal, we will be able to diagnose what is abnormal. So moving on to the first case. So basically, we get a lot of these children with abnormal ECGs, and we panic thinking that they're going to deteriorate and die. But don't panic. Most of them will be stable, and with proper recognition and proper management and a proper ECG strip, you will be able to diagnose most of the rhythms and manage them quite easily. So make sure whenever you're in doubt about an ECG rhythm, when you see a tachycardia or a bradycardia, make sure you get an ECG strip, 12-lead ECG done before you jump to giving any medication like adenosine for SVT or anything. So make sure you know what the exact heart rate is. Make sure you recognize if the rhythm is normal or abnormal. If it is abnormal, is it narrow complex or is it broad complex? And based on that, you diagnose from the ECG strip and go to your treatment part. Okay, next. So we all know broadly classifying arrhythmias into tachy and bradyarrhythmias. So the ones that are too fast and the one that is too slow. We'll be discussing them in the form of case scenarios. So you'll be answering for the most part. I'll just give you case scenarios and you tell me what the rhythm could be and how do you identify that it is an abnormal rhythm and what treatment would be the correct one to manage this specific rhythm. Okay, first case, we have a 1-month-old child presenting with URTI. He's looking pale since morning, didn't take feed properly, and mother is worried. On examination, his vital data was like his heart rate was 250 beats per minute, saturating well, not in distress. Blood pressure is also normotensive, but on palpating, you find cold peripheries, and this capillary refill time is normal. And you get an ECG done, and the ECG looks something like this. Okay, volunteers. So the ones who have already answered, you give chance for the rest of them to answer. So what can this rhythm be? So is it a normal sinus rhythm? I'm hoping I'm still audible. Is it normal sinus rhythm? Can somebody answer?
No, ma'am, there is no P wave seen.
Okay, I'll try to zoom it a little bit further. So can you move to the next slide? So next slide. Okay, so this is much closer look. So, so what did you say a normal sinus rhythm was? P wave for every QRS complex. So do you see a P wave for every QRS complex? I need PGs to answer. Please feel free to give wrong answers. That's how we all learn. Okay, I'll go into the chat box. I see that a lot of people are shy to say the thing out. Okay. Somebody is saying supraventricular tachycardia, tachyarrhythmia. Okay. So the first thing to diagnose, everybody has realized that it is a tachyarrhythmia. Okay. So is it a normal sinus rhythm? So definitely not. It's a tachyarrhythmia. So how did you diagnose that it is supraventricular tachycardia?
Narrow QRS complex, ma'am.
Okay, narrow QRS complex. Okay.
P waves are not there, so SVT, ma'am. P waves are not regular, and as you told, for the sinus rhythm, it is not regularly present for every QRS, ma'am.
Okay, so there is no P wave for every QRS complex, and this is associated with a narrow QRS complex. and not all the QRS complexes are not in the similar size and shape. So definitely abnormal rhythm, and it's looking like
Supraventricular tachycardia.
okay, good. Next slide, please.
I just want to add one point here. What is the RR variability here? The distance between each R wave, is it variable or it's constant? You can check it here in the slide itself.
If you see the sir, can you put mouse between the
Constant.
two?
Constant.
Yeah. So you can see from here itself. So RR variability is constant. That means there is no variability with the breathing. So you don't have the heart rate is not controlled by your autonomic nervous system. So it's arrhythmia. So this is one point which you can, if you have doubt that P waves are there or not there, some P waves are visible. So we are doubt, but if you see a constant RR interval, that means your heart rate is not controlled. So it is something not from the SA, it is something away from that. So like that you can know. So RR variability is the sign of sinus tachycardia. If it's not there, you can think of tachyarrhythmia. So that point I want to stress here. Continue, Pooja.
Okay. So when you look at the ECG, you can go in a manner like first you look at the heart rate. So like sir was saying, is there any beat to beat variability? Is there any RR variability? Do you see a P wave? How is the PR interval if you can see a P wave? And how is your QRS complex? So on this ECG, you can see some P waves, somewhere you can't see P wave, but you're not sure. But you can say that the RR variability, there is no RR variability, RR is constant, and the QRS complex is narrow. So this is highly likely to be a SVT. But how do you differentiate it from sinus tachycardia? So what are the differences you would see between sinus tachycardia and supraventricular tachycardia? So can we move to the next slide with the comparison strips? Okay, somebody is saying heart rate. You have a child with a heart rate of 250. So would that mean it is for sure supraventricular tachycardia? So can we move the slides? Okay, next one. Okay, so we have two strips. Can somebody tell which is which and how did you differentiate between the two? Okay, from the chat box, somebody is saying rhythm P wave before QRS. Okay.
First one has P wave and regular RR interval will form QRS complex. Second one, there is narrow QRS, but we couldn't appreciate P wave well. There is tachycardia, and here also RR intervals are constant.
Yeah, you can see both show increased heart rate, but from these strips you cannot tell if there is beat to beat variability in the heart rate with activity. So if the child is in front of you, you can take ECG strips with some exertion, and that will show beat to beat variability when it comes to sinus tachycardia. But whereas for SVT, it will remain constant. There will not be any beat to beat variability with activity. And like you rightly said, P wave is present on the first strip and there is no P wave on the second one. PR interval is constant. So it is sinus rhythm, but it is quite tachycardic. In the second strip, you can't tell PR, you can't comment on PR interval because you can't see a P wave. RR interval is constant in both of the strips. QRS complex, like you said, it is narrow. Okay, can we move on to the next slide? So this is the summary of what we've just discussed between sinus tachycardia and SVT. Okay, I hope we're all on the same page. So how do we manage the So like this scenario which I just 1 month old child, URTI, looking pale in the morning, take feed, quite tachycardic up to 250, SATs are 98%, blood pressure is normal, just cold extremities. So does he look like hemodynamically stable, unstable?
Unstable, ma'am. Old peripheries.
Okay, but blood
But
pressure is
BP is normal.
okay. And capillary refill time, central capillary refill time is less than 2 seconds. Okay, he is currently fairly stable. So what would be your first management option for a child who is hemodynamically stable? Adenosine. Somebody is saying adenosine. Okay. Somebody else is saying carotid massage, vagal maneuver. Okay. Valsalva. Okay. So how can you ask a 1-month-old to do a Valsalva maneuver? Okay, vagal stimulation. Ice packs on cheek. Okay, somebody said ice packs on cheek. Okay, can we move on to the next slide? So, quite simple. If you can evaluate the child and you see that the child is not in shock and hemodynamically stable, you can first attempt vagal maneuvers. And the most common vagal maneuvers we do in our day-to-day practice is placing a pack of ice on the infant's or neonate's face, only covering the upper part of the face and not to close the airway. So fill a plastic bag with some ice and water and place it on child's face for 15 to 20 seconds and see if the heart rate has come down, if it's reverting to sinus rhythm because of the vagal stimulation. The other measures you can try in a big child is you can give a straw and ask them to blow in a narrow straw. This is kind of trying to make them to perform a Valsalva maneuver. And the other option is carotid sinus massage. But this is quite difficult to do in a 1-month-old child with almost no neck. And there is one other practice where we use ocular pressure to reduce the heart rate, but that is currently not routinely advised because of the danger of retinal injury. So these are the vagal maneuvers that you do in a stable child. Or even in an unstable child, when you want to give adenosine, when you're trying to secure an IV line or an intraosseous line, or when you're trying to get your defibrillator ready for some cardioversion, you can, during this arrangement, without any, when somebody is available, like you have 2 more people available, you can ask one of them to do the maneuvers while you get the other things ready. So if no shock, then you can do vagal maneuvers and see if SVT is reverting. If not, next step is adenosine. You give adenosine, you give multiple doses of adenosine, still no improvement, then you can try amiodarone, still no improvement, then you can go for synchronized cardioversion. Whereas in an unstable child, you can't wait for vagal maneuvers. You can immediately try getting an access and give an adenosine bolus. And if it's not reverting and the child is quickly deteriorating, you can immediately go for synchronized cardioversion. So when I say vagal maneuvers, you're now aware of what to do. When I say adenosine bolus, adenosine, how do you give adenosine? What is the dose you would recommend? And how do you give it? Is there a specific manner we give adenosine? So what is the dose of adenosine that we give routinely?
0.1 mg per kg, ma'am. IVS should be as close to heart, it has to be there.
Okay.
And it has to be given through 2-way, ma'am. One for the adenosine, another for the NS flush.
Okay. So, okay. Can we move to the next slide?
Just one point I want to stress here. This is actually an APLS algorithm, which is mainly for European countries. And for your exam purpose, I think we need to follow PALS, which is in a US algorithm. There's a slight differences. There's not much major difference. The only thing is that dose of cardioversion in PALS is start with 0.5, I think.
Yes.
That is what I feel. And even adenosine doses, they won't go for much more than 200 mics. They won't go up. So only in the APLS algorithm, we can go up to 400 to 500 mics. So the only difference between this APLS algorithm and the PALS algorithm. But for exam purposes, just to follow PALS algorithm, that is what majority of the people in India knows.
Yeah. Okay. So based on PALS, which we follow, the first dose of adenosine, like you rightly said, 0.1 milligram per kilo, we give a rapid bolus. And then we wait and see, no response. We go for a second dose, which is double the dose of the first one, that is 0.2 mg per kilo, again as a rapid bolus. And if it is not reverting, then we head for synchronized cardioversion. So when we say synchronized cardioversion, we begin with the smaller energy, that is 0.5 joules per kilo. And then if that is not effective, we increase the dose to 1, we double it, and then again to 2. So the maximum we can give is 2 joules per kilo. But make sure the child is sedated or given some analgesic before you deliver any kind of shock, be it synchronized or defibrillation, because especially synchronized cardioversion in a stable child or a borderline child, the child will be able to feel a lot of pain. So make sure you give adequate analgesia. So, like you guys already pointed out, adenosine we give as a rapid bolus because the duration of action is within 10 seconds and it clears quite quickly from circulation as well within 30 seconds. So you should use a 2-way cannula and give an adenosine bolus followed by a quick saline flush through the other lumen. And like you rightly said, you should make sure it is in a large peripheral vein closer to the heart or a central vein. Yeah, and make sure you have 2 people while you administer this. A single person, it's quite difficult to do it. Next. So adenosine will block the AV re-entry rhythm, and that will revert the rhythm from SVT to sinus rhythm, like we see on this ECG. Okay, next. We'll move on to the next child. I hope we are clear here. Hemodynamically stable child, we can try vagal maneuvers and then adenosine. Whereas in a hemodynamically unstable child, we have to make sure we stabilize the child first. So it's better to go for synchronized cardioversion instead of delaying your time with vagal maneuvers and adenosine. Okay. Moving to the next case scenario. So we have a term baby born to normal delivery, presented to your clinic on day 2 of life with similar complaints, not feeding well, looking pale, has respiratory distress. Your CRT is prolonged, heart rate is 280 per minute. There's no murmur that you can auscultate, and the liver is 2 centimeters. And this is the ECG strip that you get on 12-lead ECG. Okay, can somebody comment on this ECG? PGs?
Atrial flutter, ma'am. Sawtooth pattern.
Okay, what do you see on the ECG? You can jump to the diagnosis later, but what do you see on the ECG?
P wave and QRS ratio is 2:1 and 2 P wave, 10 QRS complex.
Okay, you're seeing 2 P waves. Somewhere I can see 3 P waves also.
It's atrial flutter, ma'am.
Okay. So you have, yeah, it's a sawtooth pattern, typical pattern of atrial flutter. Somebody saying 2:1. 2:1. Sorry. 2:1 block. Okay. Why do you think it is 2:1 block? I think we mentioned that the heart rate was 280 per minute. So it is. So is it a tachyarrhythmia or a bradyarrhythmia to begin with?
It's arrhythmia.
It's tachyarrhythmia. That's right. So we have, as we can see, we have multiple P waves before each QRS complex. So this does not define the normal sinus rhythm clearly. And the sawtooth pattern is characteristic of atrial flutter. What is the ideal treatment for atrial flutter?
Just one point I want to add here. One person has answered 2:2 P waves and 1 QRS. Why it cannot be 2 T waves? Why you are jumped to only P waves? I seen it is very the waves are very adjacent and combining with the QRS also. So why it can be 2 T waves? Why it is only 2 P waves? Kirtana, someone Subhashri answered it. How to differentiate T waves and P waves here? Is any fact we need to just by heart?
Only one QRS complex there.
So
one QRS has one T. So only when a QRS happens, you'll get a T.
exactly. So that is unless you have depolarization, we don't have repolarization. You cannot get multiple repolarizations. So that's why until the T waves always matches with the QRS. If you have 280 QRS, you should have only 280 T waves. You cannot get more than that. So that is the logic. So that's why if you see multiple waves, that is most likely P waves. That is the waves in between QRS will be P waves. So that is the logic behind that. So always you have multiple waves in between 2 RR intervals. The other except the one will be T, others will be P waves. So anything more than 1 or 2, it will have to take it as P wave, not as T wave. So that's all. Continue.
So here we see that the rate is high and the P waves, classic sawtooth appearance. QRS is narrow and ratio, some we see 2:1 and some we see 3:1. So it's not constant. Okay, moving on to the management of atrial flutter. So in this child, what do you think? This child is quite unstable hemodynamically. He presented pale with respiratory distress and prolonged CRT. So what ideally you would do for atrial flutter?
Beta blocker can be used.
Okay, beta blocker. So what's the rationale behind using beta blocker? What are we trying to address here?
To decrease the SA node firing.
We are trying to reduce the rate. Okay. What else can we use?
Calcium channel blocker.
Sorry, calcium channel. Okay. In a hemodynamically unstable child, can we try anything else? So we had this child come to our cardiac OPD and he was quite unstable. So soon after, so initially the waveform looked like SVT. We gave a dose of adenosine, after which we could see classic sawtooth appearance on the ECG, denoting atrial flutter. So we immediately took the child to cath lab and we gave a shock. We gave a 2 joule shock, after which you can see that after the shock is delivered, the rhythm has reverted to sinus. If we move to the next strip, we can clearly see that it has reverted to proper sinus rhythm after cardioversion. Okay, it's not quite common presentation in office practice, but just a point to bear in mind. If the child presents with atrial flutter and is relatively stable, your treatment should aim at two things. One is in reducing the rate and also in controlling the rhythm. So, as you rightly said, we have to give a beta blocker to reduce the rate in a stable child. And to control the rhythm, we can try amiodarone or flecainide. One point to remember, you should never give rhythm control drug before you try and control the rate. So you have to give both as a combination. That's ideal. In an unstable child, it's always advised to go for a cardioversion, which we did. Can we move on to the next slide?
I want to add one point here. If people seen already, if you don't able to identify it as a flutter and directly go for cardioversion, if you're able to identify it's an narrow complex tachyarrhythmia, most likely supraventricular. So the moment if you identify supraventricular, what you can do is you can give an adenosine. If it's a pure SVT, it can revert back. If it is like this atrial flutter or something like there's atrial tachycardia, so many tachycardias are there. So there it can reveal the actual rhythm, whether it is a purely like SVT or is something beyond SVT. So that way adenosine can help. But the only thing I want to stress here is just without ECG monitoring, if you give adenosine, it's not going to help us. So you need to see why the child is not responding to adenosine. So you need to see what is happening to the ECG while you're delivering the adenosine. That's why always make sure that when you're delivering adenosine, you have an ECG running, whether it could be the monitor or it could be in the ECG machine. So make sure this is the first thing I want to stress. Apart from the three-way technique for the administration of adenosine, you need to remember that when you're giving adenosine, you should have an ECG monitoring. So unless you don't have ECG monitoring, you cannot pick up all this extra arrhythmias, which is not get reverted by adenosine, which needs cardioversion. So the second point, if people have to remember from this class.
Yeah, right, like he rightly said. So when you identify an abnormal rhythm, make sure you have an ECG with an abnormal rhythm while you are treating the rhythm and after the rhythm has reverted to normal sinus rhythm. So you have to make sure you have ECG monitoring all through. So when we talk about synchronized cardioversion, we use lesser energy, that is 0.5 to 1 joule per kilo as your initial dose, and subsequent doses we increase to 2 joules per kilo. And it's quite important to know how to use your defibrillator. Try to go to your unit and get acquainted with the defibrillator in your unit. Turn it on, see how many paddles it has got. Usually we have two pads that we attach, one to the right anterior part of the chest and the other to the axillary part of the chest, and we deliver the shock. So before delivering shock, make sure you have given adequate sedation or analgesia. Make sure you have an ECG diagnosis. And when you deliver the shock, you have to announce that you're charging the defibrillator and that you're going to give a count of 3. So you say, I'm going to shock them, and you count 1, 2, 3, I clear, you clear, all clear. This is from your pulse. And everybody should be clear of the table, all the oxygen attachment should be disconnected, and the shock has to be delivered. And then you check the monitor for the rhythm. And you see if the SVT or your atrial flutter rhythm has reverted to normal sinus rhythm or not, or if it has worsened to any abnormal rhythm. So you have to always keep your eyes on the rhythm even after delivering the shock. You have to see if it has reverted to normal or has worsened or has remained the same. Okay, if it worsens based on the presence of the rhythm on the monitor, you deliver the required shock or give medication. If it continues the same, you try and increase the dose of the next shock that you deliver. And if it reverts to normal sinus rhythm, then you wait and monitor for some time if the rhythm is continuously staying in sinus or not. Okay, can we move to the next slide? So this is just a briefing of treatment strategy. So you use rate control drugs and rhythm control drugs. Rate control, we usually use beta blockers and diltiazem and verapamil. And rhythm control, we usually use flecainide and amiodarone. Moving on. So this is commonly seen condition in newborn babies, and the mechanism is re-entry mechanism. And I'll skip this mode of action and everything. Okay. So management of any shock, any rhythm abnormality, it should start with your airway breathing circulation, ABC, and then if everything else is okay, you head with your cardioversion or your cardiac drugs. Okay. So yeah, like I said, flecainide should not be given alone, and it should be given with a rate controlling drug as well. Okay. Next one. Moving on to the next case, we have a term baby, meconium aspiration syndrome needing ventilation on maintenance IV fluids. Is currently in renal failure, and there is a sudden drop of blood pressure when you're on call, and there is a rapid increase in heart rate, and the ECG looks quite abnormal on the monitor, so you get a 12-lead ECG, which looks something like this. So can somebody say what we are looking at?
Wide QRS complex, ma'am.
Okay.
Ventricular tachycardia.
Okay. Can you see P waves?
Ventricular fibrillation.
Somebody said ventricular fibrillation. So how do you differentiate between ventricular tachycardia and ventricular fibrillation?
In ventricular tachycardia, the QR is wide, ma'am, and in supraventricular tachycardia is narrow. So it's narrow one.
Sorry?
In ventricular fibrillation, QRS complex up and down.
QRS complex is up and down. Okay. Hello. Okay. This is clearly is this a tachyarrhythmia or a bradyarrhythmia to begin with?
Tachyarrhythmia.
Okay, that's good. And do you see P waves?
No,
Okay.
ma'am.
We'll move forward, we'll move quickly. Okay, so this is the tachyarrhythmia, and it is a wide QRS complex or a narrow QRS complex?
It's wide QR.
Okay, what are the common presentations of wide QRS complex tachyarrhythmias?
Right.
How often do we see ventricular fibrillations in pediatric age group? It's quite rare that we see ventricular fibrillation. This is a child with ventricular tachycardia. Can you move to the next slide? So how do you manage a child with ventricular tachycardia? This child is quite unstable, but has a pulse and has a ventricular tachycardia rhythm. So what do you do?
DC current, ma'am.
What is the first medicine you try? What is the first drug you try in child with ventricular tachycardia?
Immunoderm.
Okay, so we tried it. So what's the dose we usually give?
5.
Yeah, 5 milligram per kilo, and we give it over 1 to 4 hours, depending on the severity of the child status. Okay, next slide. Okay, this is again APLS management, but basically, if pulse is present, you go for amiodarone, and we give 5 milligram per kilo over 1 to 4 hours. And think of a synchronized cardioversion if the rhythm is still resistant. We have given a dose of IV amiodarone for this child, and the rhythm has reverted to normal sinus rhythm. Similar scenario, if this child suddenly collapses, has a cardiac arrest, and you palpate and there is no pulse, and you put on the defibrillator on, you see a VT rhythm with no pulse. So what's the ideal management you do? You go for your pediatric cardiac arrest algorithm.
Chest compression
Right?
only.
Yeah, we'll start with chest compressions. We'll attach the defibrillator. We'll see what the rhythm is. If it is pulseless VT, what do we do if it is pulseless VT?
Only chest compression and others volume should be managed.
Do we give a shock for pulseless VT?
No, ma'am. No, ma'am. Only compression will be enough.
What are the shockable rhythms?
A ventricular tachycardia and other arterial.
Yeah, so if pulseless VT is an indication for shock, right? You use your defibrillator and you give a you deliver a shock at what energy do you use for defibrillation? PGs?
2 joule per kg.
Okay, yeah. So for synchronous cardioversion, we start with 0.5 to 1, whereas for defibrillation, we use 2 joules per kilo. Because this child is completely collapsed, pulseless, we deliver a higher energy. Okay. So moving on, we have given amiodarone and we've reverted the rhythm, normal sinus rhythm here. Okay. This is the PALS algorithm for pediatric tachycardia. So for any child with tachyarrhythmia, you do your initial assessment, ABCD, get an access and do a 12-lead ECG. And based on your ECG rhythm, you recognize your rhythm. You see if it is a narrow QRS complex arrhythmia or broad QRS complex arrhythmia. If it is SVT and stable, you go with medical management. Unstable, you give cardioversion. If it is VT and stable, you give amiodarone. Unstable, you go for cardioversion. Okay. Moving on. Next one, we have a 13-year-old child. Next case.
1 minute. Just I want to have a question here. And what is type of cardioversion you give in when child is in cardiac arrest? And what is the type of cardiac version you give when child is very stable? Stable means you have not in cardiac arrest. Like previous scenario, like SVT and VT, like child is not in cardiac arrest, or child is little unstable, but relatively stable. So what type of cardioversion you give there, and what type of cardioversion you consider during cardiac arrest? Because in VT without pulse also, you are going to give like you act like in cardiac arrest algorithm only. So that's the major difference, because you should know this difference, because when you are operating your defibrillator, it will be must to select the mode in that. So based on what situation you are dealing with. Like Madam already previously told everything. So I just want to emphasize again that point, because that's a very important point. Because I have seen so many people given shock without selecting that button, even in SVTs. That's why I was concerned.
Relatively stable children will give synchronized cardioversion.
Okay, during cardiac arrest?
DF will be better, sir.
Defibrillation. So use the words like that. Cardioversion is synonymous with synchronization. Defibrillation, there is no synchrony. The main thing what you're synchronizing is the R wave. If you're able to see proper ordinary QRS, you can go for synchronized cardioversion. But the rhythm is not showing organized QRS. There is a bizarre QRS waves. Then that monitor, that defibrillator cannot select the R wave. So that's why it cannot deliver the shock. If you put a sync button during the cardiac arrest, you will not deliver shock. That's why you should know when to switch the sync button on, when to switch it off. So if you have organized QRS like SVT and VT with pulse, then you can try synchronous cardiac version. and you have other rhythms, you need to go for without synchrony, you have to go for defibrillation. So that's the one point I want to stress. So we'll move on from.
So next scenario, we have a 13-year-old child playing football and suddenly collapsed, and you see he's pale and quite cold, shallow breathing, very poor perfusion, and when you try to feel a pulse, you can't feel a pulse. And you do an ECG immediately, or you try and connect a defibrillator that's available, and you find this rhythm. So what is this rhythm? In a child who collapsed, no pulse.
It's a ventricular fibrillation.
Okay, it is ventricular fibrillation. You see a chaotic, uneven, irregular rate, irregular rhythm. So, how would you address a child who collapsed, no pulse, ventricular fibrillation? What is the algorithm you follow? So you address it as cardiac arrest, right? Sorry?
Defibrillation.
Somebody ask? So you immediately, okay, what? How do you start? Do you start your CPR as per your cardiac arrest protocol? So you first start your chest compressions, right?
Yes, ma'am.
Okay, and what shock do you deliver?
Defibrillation, not without shock, ma'am. Cardioversion.
Not cardioversion, exactly. So you go for defibrillation, higher energy is delivered, and so when we say defibrillation, it is unsynchronized shock, and you give a shock for VFib. Meanwhile, you after delivering a shock, you still continue your chest compressions, giving your adrenaline bolus, and again try and reassess your rhythm. Okay, moving on. So, like I said, this is a VFib. Can we move on to the next slide? So, we have pediatric arrest algorithm as per PALS. So, you give 2 joules per kilo shock first time, and if it's still going back to pulseless VT or refibrillation, then we try a second shock and double the dose, 4 joules per kilo. And after that, each shock should be double the previous dose, and we go up to a maximum of 10 joules per kilo. Okay, and we continue chest compressions, airway management, and adrenaline all through the process, even after delivering the shock. Okay, moving on. So, how do you deliver the shock? So, similar to what I have discussed before, you have to make sure what mode you select on your defibrillator. So, you select the defibrillation mode, set the energy at 2 joules per kilo. And then similar procedure, you charge the defibrillator, say you count 1 to 3 and say I clear, you clear, all clear, and give your shock. Soon after the shock, you resume your chest compressions. That is very important. Okay, next one. So this post defibrillation, we see that the rhythm has pivoted to sinus. Coming to the next child, so we have a 3-day-old baby who weighs 3 kilos with mild cold, not feeding very well. And you notice that the heart rate is quite low, 70 beats per minute. And you get an ECG done on this child. So what does this rhythm look like? So is it a tachyarrhythmia or a bradyarrhythmia?
Bradyarrhythmia.
Okay, okay, heart rate is 70. In the newborn child, expected heart rate is between 120 to 140. So, okay. So is it, what kind of bradyarrhythmia is it? Okay, we'll discuss, we'll move forward. So it is a child with a complete heart block. So what are the types of heart block we know? Tejas, okay, you're already seeing the slide. So these are the important pointers to remember for each heart block. So first degree heart block, your PR is prolonged. Second degree heart block, you have a progressive prolongation of PR interval in Mobitz type 1 until you have some missed beats. So your PR interval will slowly progress and then you'll have a missed beat and then this continues again and again. In Mobitz type 2, your PR interval is constant. But some of the P waves don't transmit across the AV node and give QRS complexes. Okay, so you'll have missed beats. And the third degree is there will be no relationship between P wave and QRS complexes. So in most of the third degree blocks, your ventricular rate will be constant because it has no correlation with the P waves. Okay, so none of the P waves, none of the atrial impulses are reaching the ventricle in the third degree. So I've got some ECG rhythms coming up next. So you diagnose based on these findings. So this is a child with bradyarrhythmia, low heart rate. So what type of heart block is this? So you see your P wave, you see your QRS complex. Do you see that the PR is prolonged?
First degree heart.
Yeah, that's right. It's a first degree heart block. Okay. Next one, this one. Do you see P waves? Yes. Do you see QRS complexes for all your P waves? No. Do you see PR prolongation? We see that the PR is prolonged and then slowly you have a missed beat. If you can see in lead 2. Okay, it's Mobitz type 1. Next rhythm. So what is this rhythm? Series. So after Mobitz type 1, at least what follows Mobitz type 2?
Mobitz type.
Yeah, okay, here you see constant PR interval. That is a characteristic feature of Mobitz type 2. And not all P waves are transmitted to give QRS complexes. So this is a second degree heart block, which is type 2 Mobitz. And the first rhythm that we saw with the scenario was complete heart block. So this is the comparison between all 4 rhythms. The first one is a first degree block with prolonged PR. Second rhythm is progressive prolongation of PR. That is Mobitz type 1. The third rhythm is constant PR interval. And some P waves are missing their QRS complexes. So this is Mobitz type 2. The last one is ventricular rate independent of the P waves. So there is no relationship between the P and the QRS complexes. So that is complete heart block. Okay, that's all. So what is the management for heart block? So you have a child with congenital heart block. You have a newborn baby in your unit with congenital heart block. What is the first thing you'll do? You do a ECG. You diagnose what heart block it is. What is the management? PGs, you have to answer this. What do we ideally use?
Orciprenaline or isoprenaline infusion.
Yeah, exactly. So we use orciprenaline and isoprenaline. So how do they work? Orciprenaline, isoprenaline. Where do they act? What do they do? So they are basically beta adrenergic agents and they increase your heart rate. Right?
Yes,
So
ma'am.
you started your isoprenaline infusion and still the child's heart rate is still low, blood pressure is still borderline. What else can you add on?
Atropine, ma'am.
Atropine.
Adrenaline infusion.
Yeah, adrenaline. We can start on inotropic support. We can give adrenaline. So your orciprenaline, isoprenaline, and your inotropic support in a congenital heart block, unstable child is only going to bridge towards your definitive management. So what do you how do you manage this baby? What is the permanent management plan?
Pacemaker.
Pacemaker.
So we initially try for temporary transvenous pacing, and then after stabilizing the child, we go for a permanent pacemaker. So you get a child with
daily ఒక పేపర్ రాయండి. నేను 3 days లో బుక్ అంతా రాయిస్తాను. లైక్ ప్రాక్టీస్ చేస్తా ఉంటే ఆటోమేటిక్ గా లెటర్స్
Others can mute.
తెలుగు ఇచ్చినాడు మీరు హోంవర్క్ చూపిస్తాను.
Galaxy S20, please mute yourself.
Okay, so we'll go ahead. So basically, you start the page. So you have a child, newborn, born to SLP mother with congenital heart block and quite unstable. You immediately start them on isoprelin infusion and some inotropy and drip infusion. You plan for a temporary pacemaker and get it transferred. And after the child stabilizes and hemodynamic is stable, you go for a permanent pacemaker. Okay, moving on. So this child we have done transvenous pacing in our unit. And the child has been stabilized. We went for permanent pacemaker. So these are the short indications for permanent pacemaker. Any symptomatic child with poor LV function due to low heart rate, you go ahead pacemaker. In an infant, heart rate less than 55, and a child with congenital heart disease and having a heart rate less than 70, or an elder child, go for a permanent. Okay. Final case scenario. So we have an 8-year-old child who presents with kind of palpitations, and we have a family history of an uncle who died all of a sudden. And you evaluate the child.
Sweet ice chocolate పెట్టద్దు.
So you see, so can you read this? Do we have?
ఇప్పుడు మా మనవాడు వచ్చింది కదా, ఇంటికి వచ్చి సెల్లు లేకపోతే గొడవ లేకపోతే కొడతాడు, ఏదో అట్ట బయటికి పంపించి ఏం చేయలేం. అందరూ అట్లా ఉంటారు.
So we see P waves, we see QRS complex, we see T waves. So is there anything abnormal? So when we discussed earlier what is a normal sinus rhythm, we said normal PR and QT interval, right? So how is the QT interval here?
Prolonged.
Yeah, so this is a prolonged interval. So how do you calculate corrected QT interval in the child? Manoj, Ketla?
From start of the Q wave to the end of the T wave, ma'am, that will give the QT. The number of small boxes we can multiply with 0.04.
Okay.
For the corrected one, ma'am. For the corrected QT interval with the QT calculated, we have to take square root of the RR also, ma'am.
Okay, very good. So which RR you will use for this QT? So the RR preceding the QT that you are calculating, you have to use for the Bazet formula. Okay. So we'll move on to the next slide. This is a long QT syndrome. We have 12 syndromes in the spectrum, and they present with palpitations, syncope, seizures, and sudden death. So to calculate this QT prolongation, we calculate corrected QT interval using the Bazet formula. So how do we calculate the corrected QT interval? She just said. So can we go to the next slide? So you calculate QT and RR. So QT is measured from the beginning of QRS to the end of T wave. And the small blocks you see here, we have like 6 small blocks Q to T that you multiply with 0 to get QT. and you divide it with root of
అయ్యో
for the R
వద్దునా.
is the QT, and
Hey,
you use the
ఏమది?
R that is preceding the
దెబ్బలు పెడితే నీకు
and if it is on an average more than 40 seconds,
ఆ?
you consider it as long QT.
డాడీ ఉన్నప్పుడు ఏమో తీసుకుపెడతా రోజు అన్నావు
Galaxy S2,
నేను ఎక్కడికి రావాలా
Dr. Galaxy.
పైకి పిలిచపోయినా
రెడీ చేసుకోదాం.
పోయిరా పో మళ్ళా డబ్బులు ఇచ్చిందా పైకి పోయి మరి ఆపో
వద్దులే వద్దులే సరేలే పోదాంలే పట్టుకో
కొద్దిగా డల్గున్నాడు రాయమో
ఏం లేదా ఇదే చదువుకోమని
ఇట్లా లేదు అక్క కూడా అనింది ఏమో మా అమ్మ నాన్న ఏదో డల్ అయింది
పోదాం హైదరాబాద్ పోదామా
So any above 450 is significant. You consider it as long interval. And the mainstay of treatment for this is beta blockers, and sometimes in history of family deaths, you can go for implantable cardioverter defibrillator that will deliver a shock whenever your heart goes into arrest rhythm. Or you can try surgical sympathetic denervation. Prophylactically, you have to identify the triggers, and you have to avoid the drugs that cause QT prolongation. There are a lot of drugs that cause QT prolongation, so you make sure you don't prescribe those for the children, and you avoid the triggers like some competitive sports or startle responses or excessive emotions of anger or crying too much, and you have to avoid dehydration. So these are some of the precautions you take for children with long QT. Okay, so those are our 6 scenarios today. We try to keep it as simple as possible without confusing you with the mechanisms of AV, RT, AV and RT. I hope we get some points to take home today. The main things being, you have to recognize your normal sinus rhythm. Only then you will be able to identify your abnormal rhythm. And how to give adenosine. You have to use saline flush and a two-way cannula and identify large peripheral vein or central vein in the flush, and what vagal maneuvers you can do, and how to use your synchronized cardioversion and defibrillation, and in what scenarios you will use them. So these are very important. Make sure you take a ECG when you identify an abnormal rhythm while giving treatment and after reverting to normal rhythm. So these are my take-home points for you. Over to Raven sir, if there is anything you want to add, please add on.
It's a clear presentation, very much informative, and I hope everyone got something from this presentation. And we have to thank Dr. Vikram for educating us in this, who is a pediatric cardiologist in managing this complex arrhythmias. So we have a lot of expert arrhythmias. That's why. But I think we got all these reference from the peripheral centers only. It is not from like the patient is coming and landing in our center. So the peripheral doctors recognize the rhythm, they found it is abnormal, and then only they refer to us. But with this, we are attempting that we can do at least a shot of adenosine in the peripheral setup itself. No need to worry about the child can land up in arrest there itself. But adenosine is a safer option, and it's not going to act more than 30 seconds. So I think trying an adenosine in a peripheral center to revert SVT, I think it should be a must for every practice. So with that, if any questions, we're happy to take. If no questions,
ఒకటి అన్నా బాగానే ఉందా తీసేసి వేరే చోట పెట్టిస్తారా వేరే చోట
Sir, my one question is that if any child having the pacemaker and if he landed in the shock, can you give the cardioversion or defibrillation in that case? If knowing that the child have already permanent pacemaker.
ఏ ఊరు మళ్ళా రావాలి వినబట్లేదు
Yeah, I mean, if you have a pacemaker, guidelines, you have to make sure that you don't position your paddles or pads directly over the device.
150.
So you can
నిన్న
divide
పెట్టారా
subcutaneous tissue, right? So make
ఎప్పుడు
sure
పెట్టారు
the paddles are not
కళ్ళు
placed
వచ్చినాయి
over the device.
అచ్చా ఆయన
You can still use defibrillation to deliver
అచ్చాడా
shock
బస్
with child with pacemaker and who is in arrest.
Okay, ma'am. And ma'am, if the bradycardia and we don't have isoprenoid, can you use atropine in that situation, or better go for adrenaline in situation?
It's better to go for adrenaline. Ideally, we never use atropine with heart block. You always start with adrenaline, dopamine, and whenever you have availability of isoprenoid, you add on isoprenoid.
Thank you. Thank you.
Okay, thank you so much for your time today. I hope we learned something today. If you have any more queries, we can discuss them with the next session. Thank you so much.